It's gone.
Oh my god.
They're really favorite people.
Yeah.
There. I'll leave the door open for now.
I need it back.
No,
It hasn't exposed.
no, I think it says just type it in
I didn't know
paragraph
you did that.
format, so like answer here, answer here, answer here.
I
So like
don't
if
know if
there's
it's.
three
Oh.
questions or whatever in this little
She
section,
said that there.
3 seconds to answer that question.
Okay.
Can you guys see me? You may have to unmute yourselves, by the way, because
We
you're
can't see
behind
you.
me, so if someone has a question, you'll have to like say Miss Martin.
We can't see you, Sarah. Or
You can't see me? Let's see.
Sorry, I'm just making sure I'm awake. Sorry.
I got it. I got it.
It's alright.
Is the camera working now?
Yes.
Perfect.
Oh, there it goes. There it goes.
I'm like asking her questions and she's talking about work. School. Take me with you.
Wow, look at you. You did well.
Yeah.
Oh, yeah, I didn't, she was great. Just.
Is everyone here? Does anyone notice anyone missing?
Lindy and Katie are here. Katie and Lindy. Zarel. Yeah, we went to three.
Okay, well, it's 8:02, so we'll go ahead and get started
Chelsea, Katie, and
on the Enid campus.
Around Katie and.
Chelsea's right there. Chelsea's
Jamie.
right there.
Well, you know,
Zarel.
since people are tired, we're kind of meandering in. That's okay. Well, it's recorded, so whatever they miss, they can go back and watch. So, since it's 8:02, 8:03, we'll go ahead and get started. So, how did clinicals go this week? How are we feeling? Feeling good? Thumbs up? Middle thumbs, thumbs down? Okay. Good, good. I know it's a lot, especially when you're first getting started, but hang in there. The more you have, the more you'll get used to the process and what the paperwork looks like and the flow of the unit that you're on. So it'll get better. If you felt like it was a hard week, it'll get better. If you felt like it was an easy week, then that's good. I'm glad. So today we are going to be talking about the endocrine system. Specifically the endocrine glands and how they help to regulate our hormones. We're going to be talking about hypothyroidism and hyperthyroidism, and we're also going to be talking about diabetes. I have a couple of learning activities for us to do as we go through the day to help you remember the content and also so you don't have to just listen to me talk for like 4 hours straight. And then we will do a review for exam 2. At the end of lecture, we'll do a Kahoot to help you guys prepare for the exam that we'll have a week from today. So let's go ahead and get started with our endocrine system here. All right, so these are our objectives for the chapter. The main things we're just going to be focusing on, like I said, is hormones and how they affect our body, and then especially how those things start to change as the patient ages or if they have genetic factors. So we'll look at all of those things. So what is the endocrine system? The endocrine system that's made up of ductless glands, so they release hormones directly into the bloodstream. Hormones are small, but they're really powerful chemical messengers, and they send messages to the rest of the body on how they should react. So the main reason our body is doing this is because we want to maintain homeostasis. So think about your body as like, you know how some of the newer thermostats in houses, you can set it so that you want to keep your body or your house between like, I don't know, 68 degrees and like 72 degrees, and you can set it in both directions. Think of that as your body maintaining homeostasis. So it wants to maintain between this guideline and this guideline, and it's going to use the endocrine system to help it maintain homeostasis in that way. So these different hormones do a lot of different things with a lot of different organs in our bodies, and we'll go over those. But some of their main roles are to help regulate our fluids, our electrolytes, our glucose, our body temperature, help us maintain nutrition, and they do a lot more than that as well. So think of it as this ductless gland releases the hormone directly into the bloodstream, and then the bloodstream takes it to the target tissue or organ that it's meant to be helping. So we have lots of different endocrine glands. If you think of these different glands as like departments within a company, here's kind of how they would break down. So the adrenal glands, those sit on top of your kidneys. They're sort of the emergency response team. The gonads are testes and ovaries. Those are our reproductive health division. The hypothalamus, that helps to make really big decisions for our body. So you can think of it as like the big boss or the CEO. The pancreas, that's the glucose control center. The parathyroid, that helps with calcium and phosphorus and managing those. And then the thyroid manages our metabolism. So each gland, they have a unique hormone that keeps the body running smoothly, trying to maintain that homeostasis. And here is a picture of where you can find all of those glands. So the hypothalamus and pituitary glands, those are in our brain. The thyroid gland sits in the neck. The parathyroid gland is just behind the thyroid gland. Our adrenals sit on top of our kidneys. And then we have testes for males, ovaries for females. And then our pancreas is right here. And we'll talk a lot more about the pancreas as well when we get to our diabetes chapter. So here is a picture of our thyroid gland. We'll be talking about that a lot today. And so the hormones are released based on what the body needs in that moment. You only get what you need and when you need it. So there are receptors in our body at the destination for the hormones that receive and then activate that hormone for its abilities. And this is what that process looks like. Here's a receptor, and then the hormone comes in, and it's recognized as being there to do a job, so the receptor receives it and activates its abilities. So our negative feedback mechanism, that is what helps us to maintain that homeostasis in our bodies. So again, think about that home thermostat analogy that you have set between like 68 degrees and 72 degrees. So if it gets too hot, so for example, like if you have high blood sugar, then the thermostat tells the AC, which in this case would be insulin, to cool things down. And then when levels return to normal, the secretion of insulin decreases. So that example ties in with like if we have high blood sugar, the body releases more insulin. If we have low blood sugar, then the body releases glucagon to help raise the blood sugar. So that's a good example of how it goes in both directions with that negative feedback mechanism. So our adrenal glands, they sit on top of the kidneys like little party hats, and then they split into two major divisions that do two different functions. So the adrenal medulla, that's that emergency response team that we talked about, and it releases epinephrine and norepinephrine, which can help initiate our fight or flight response when we're in dangerous situations. So it's kind of like your panic button in the body. And then the adrenal cortex, that's more of our long-term response to things. So it releases aldosterone, which helps us to maintain our salt and water balance. And then also it releases cortisol, which helps with our stress and energy management. So think the adrenal medulla, its response is fast, that fight or flight. And then the adrenal cortex, it's that slow and steady regulation of our salt and water balance, and then the cortisol for our stress and energy management. So breaking down aldosterone and cortisol, aldosterone is our salt and water saver, so it increases blood pressure by retaining sodium and water. So when it senses that our blood pressure is low, when our body senses that our blood pressure is low, aldosterone is released to retain that salt in water or sodium in water and increase our blood pressure. And then for cortisol, that's what manages our body's stress. So it affects our mood, our immune system, our energy, and that is something that is released more long term. So our gonads, these are dormant until puberty. So they're triggered by pituitary hormones, and then that leads to the maturation and secondary sex characteristics. So testes produce testosterone, and then ovaries produce estrogen and progesterone. And then the ovaries are controlled by gonadotropic hormones, also known as FSH and LH, from the anterior pituitary in our brain. So they're kind of like the activation switch. So the hypothalamus, again, this is our like big boss or the CEO of the endocrine system, is making the big decisions about what needs to happen. So it produces releasing and inhibiting hormones. They travel a very short distance to the pituitary gland. So the pituitary gland is the one that receives the orders, the marching orders from the hypothalamus, and it's the one that gets things done. So kind of think of your pituitary gland as like the middle management that is receiving the orders and is making sure that things get done. So that pituitary gland, it's really sensitive to the body's needs. So it responds to stress, temperature, sleep, and emotions, and it helps regulate our hunger as well. And its performance can be influenced by things like drugs, diet, lifestyle, illness. So that's why when any of those factors are at play, it's also going to affect like your stress level, your sleep, your emotions. And then here's the hypothalamus and your pituitary glands. So think of it again as like the hypothalamus is the CEO, the pituitary is like that middle manager that takes the orders, and it's the one that tells the other glands, this is how you need to respond to this. So the pancreas, it has dual roles actually. It's both endocrine, so it's in the endocrine system, but it also helps with our digestive system. So it's a wearer of many hats, but as it relates to the endocrine system, it helps to produce glucagon and insulin. So think of insulin and glucagon as like opposite teammates that are working together to regulate our blood sugar. So glucagon raises our blood sugar, and then insulin stores or moves blood sugar into the cells so that it lowers our blood sugar. And here is what our pancreas looks like. And then our parathyroid glands. So these are some tiny but mighty glands. They're located on the back of the thyroid. They secrete parathyroid hormone, which helps to regulate our calcium and phosphorus balance. So think of parathyroid hormone. You'll hear it referred to as PTH. Think of it as like a calcium banker or like store. So it withdraws calcium from the bones to keep our blood calcium at safe levels. It also works, the parathyroid gland, it also works with kidneys and our GI tract to help regulate calcium. So when you're thinking of parathyroid, think calcium and phosphorus balance. Thyroid gland is very important. It's a butterfly-shaped gland in the neck. When you're assessing it on your patient, you can feel it right about here. It produces T3 and T4, which help to manage our metabolism, which, as you can imagine, is very important. Our metabolism is kind of like the body's speedometer. It helps determine the speed at which we're going. So in our next chapter that we go over, we'll talk a lot more about the thyroid and what happens when our metabolism is going too fast, which we see with hyperthyroidism, or whenever our metabolism is going too slow, which is what we see with hypothyroidism. And then also the thyroid gland, it produces calcitonin, which lowers calcium. So again, that's the opposite of the parathyroid hormone, which helps to raise our calcium that we saw with our parathyroid gland. So the thyroid gland produces calcitonin, which helps lower our calcium. And then our thyroid gland must have iodine from our diet in order to be functioning at its optimal levels. So we get that from like seafood and iodized salt. So there are some endocrine changes that we'll see associated with aging in our older adult population. The glands tend to slow down. They don't really work as well as they did. Some other changes that we'll see is the prostate enlarges. And then also for our female patients, the ovaries stop working, and that's also known as menopause. So these changes in the endocrine system can lead to some problems like chronic illness, poor sleep. Also, some of the medications that they take can affect their hormone balance. So that's why it's important that our older population, that they undergo regular screening with a primary care provider to help catch any changes happening with their endocrine system early. So we want to ask, what does that assessment look like if we have a patient coming in and we're wanting to assess their endocrine system and how it's functioning overall as a whole? So we want to ask about any changes that they've had in their level of energy, if they've gained or lost any weight, any problems that they've had with elimination, like with urination, any issues with their sexual function, any changes in their physical appearance. So if they're having any changes in in their hair, like if it's become really thin or if it's falling out, ask them if they've had any skin changes. So if their skin has gotten really thin or fragile, and ask them if they've had any changes in their facial features or in their voice. If they've had changes in their voice, that can be a sign of endocrine problems, or it can also be a sign of the thyroid being enlarged. So we want to make sure that we're updating the thyroid for enlargement, because that can be a sign of hyperthyroidism. So for our physical assessment, again, we talked about those endocrine problems, changing some of their physical features. And then if you do notice that a patient has an enlarged thyroid gland, we want to use our stethoscope to check for bruit over the thyroid gland. So we literally just put our stethoscope over the thyroid gland and listen for bruit, which is like a whooshing sound. It's related to an increased blood flow going to the enlarged thyroid gland, and that's something that we see with hyperthyroidism. Endocrine issues can also affect their mood, personality, self-image. So an example of that is with Cushing's disease, which we see with an overproduction of cortisol in the adrenal glands. That can lead to some body image concerns because they tend to experience like swelling in the face, and they tend to have problems with their weight. So that's something that we can see with Cushing's. That's an example of why we want to perform a psychosocial assessment on our patients. Some of the labs that we'll look at their hormone levels. We'll do urine tests because hormones are secreted in our urine. We can do glucose tests if we have concerns about blood sugar. For the 24-hour urine test, let me show you all this next slide here. This is a really important slide to memorize. You might see this again at some point, but we'll talk about for the 24-hour urine test. So start the collection at a convenient time because they're going to be starting and stopping it at the same time. So if 1 a.m. is not a convenient time for them, don't start it then. They want to empty the bladder completely into the toilet, not into the container. And then that is going to be the start of their time. So they're going, let's say they started at 1:00 p.m., completely empty their bladder, right? 1:00 p.m. on the specimen container. And then from then on, they need to urinate into a separate dry container, like a hat that they have in the toilet, and then put all of the urine that they produce in that 24-hour period into the container. These containers are usually stored in a cool place, like in the refrigerator. If they miss a single sample, so if they accidentally forget or if they miss the hat or something and it goes into the toilet, then unfortunately they have to start over. And then we also want them to avoid taking any unnecessary drugs that could affect their endocrine system while they're doing the exam. So just to review some of our main concepts from this chapter. So for the endocrine system, if something is amiss or going wrong, symptoms can be slow and sneaky and kind of hard to notice, like with hypothyroidism, or they can be really sudden, like in an adrenal crisis. And then we want to be able to distinguish between normal aging and some of those normal endocrine changes that we can see versus endocrine disease and when something has potentially gone wrong. We want to support our patients with any body image concerns that they may have. And then also educating our patients that misusing steroids or hormones will disrupt their endocrine system. So let's do some practice questions here. So which client assessment finding alerts the nurse to perform a detailed endocrine assessment? Select all that apply. Alva, I think you guys are muted. You might need to unmute. What do we think here? Don't everyone speak up at one time.
Everything except D.
Yes, Kelly, you got it. Everything except for D. So if our client comes to us and they're reporting fatigue, weight gain, if they say that they're cold all the time or that they're having changes in their hair texture, that their hair is pulling out, then we are going to be concerned that they could potentially be having some endocrine issues. Okay. Or peripheral pulses are more likely associated with cardiovascular diseases.
Thank you.
So which assessment finding in an older adult client does the nurse identify that may be indicative of an age-related decrease in antidiuretic? I think I heard someone say A. Good. So dilute urine and dehydration, those are symptoms that result from those age-related decreases in the antidiuretic hormone. So good job. Let me exit out on this here and I'll pull over our next one. Any questions with just kind of that overall assessment of the endocrine system? Feeling okay about it? Sorry, I feel bad because you guys are like behind me, because I have to literally like turn around and look at you. Okay. So let's kind of focus in. So this is still related under the endocrine umbrella, but we're going to look more specifically at the thyroid glands and what it looks like whenever a patient is having issues with their thyroid gland. Okay. So hypothyroidism, again, like we talked about in the last chapter, the thyroid, when you're thinking of the thyroid, think of metabolism. So when something is wrong with our thyroid, our metabolism is either going to be overperforming, like with hyperthyroidism, or underperforming, like with hypothyroidism. So it's going too slow. So think of hypothyroidism as like the body is doing everything in slow motion. So because there's not as much of that thyroid hormone circulating in the body, we're going to have decreased metabolism in every system of our body. So the symptoms are really widespread because the thyroid hormones really affect almost every cell in our body. So when a patient has hypothyroidism, it's like their body is kind of running on low power mode. Everything slows down from their digestion to their heart rate to their mental processing speeds. So here's a picture to help you remember what a patient looks like when they are experiencing hypothyroidism. So we're going to see the hair loss. This says apathy, but I think a better word that we'll see is usually like depression, lethargy. They're really tired. They have dry skin. It's really coarse. They'll have muscle aches and weakness. They'll have constipation. They'll be really intolerant to cold. And then with that hair loss, we'll kind of see a receding hairline. We can see some facial and eyelid edema. And then anorexia, like their appetite has decreased. We'll see brittle nails and hair. And females will see menstrual disturbances. And then some of our later clinical manifestations that we see if it's left untreated is a lower heart rate, that bradycardia, a lower temperature, weight gain, decreased level of consciousness, and some cardiac complications. So think about that with hypothyroidism. We worry about having some cardiac issues with that bradycardia if it's left untreated. So myxedema coma, it's rare, but it is a life-threatening emergency that we can see in severe untreated hypothyroidism. It's usually triggered by illness or surgery, if they've had any trauma to their body, if they suddenly stop their thyroid medication, or if they're on chemo. The body just can't really handle that stress and it goes into a myxedema coma. So what that looks like is it leads to really dangerously reduced brain, heart, and lung function. And they can also present with respiratory failure, hypotension, so that low blood pressure, confusion, and even possibly coma. So like their level of consciousness is 0. So think of it as like the body's metabolic system is just completely shutting down, like the battery has died. So again, that's really rare, but it's something to be aware of as a potential complication of hypothyroidism. So hypothyroidism, there isn't any known way to prevent hypothyroidism, especially if someone already has the genetic predisposition for it. But what we can do is we can prevent complications by detecting it early. If a patient is presenting with any of those symptoms, it's important that we draw those labs to check like their TSH, which is their thyroid stimulating hormone, their T3, their T4, these hormones that are produced by the thyroid to see if they're low so that we can identify if the patient is experiencing hypothyroidism. Because if they are low, we can start them on a medication called Synthroid, which and another name for it is levothyroxine, so you might see it as both ways. But one important thing to note is that Synthroid, if a patient is taking that, it's a lifelong medication. So they're going to take it for the rest of their lives. They can't stop it just because they feel better or because the labs are looking better. So again, with our patients with hypothyroidism, our nursing priorities are to prevent that hypotension, the low blood pressure, support their cognition because confusion can be common, improve their gas exchange, so their respiratory muscles can be weakened. And the main thing is that we want to teach our patients when they're taking Synthroid to take the medication at the same time every day on a completely empty stomach. And then they need to wait 45 minutes before eating anything. So a common time that most people will take their thyroid medication is first thing in the morning, and they'll just like keep a water bottle right there next to their sink, and like before they brush their teeth or do anything else, they'll just take their medication, and then they need to wait 45 minutes before they put anything on their stomach, because if they take it with food in their stomach, it affects the absorption of the Synthroid and it's not as effective. So when we're assessing a patient, we want to gather their history. So history reveals, again, like signs of that slowed metabolism. So if they're reporting fatigue, sleeping a lot, if they're feeling weak, If they say that they're cold all the time, like they're always wearing multiple jackets when no one else is. If they're experiencing constipation, muscle aches, some other things that we'll see is low libido, weight gain despite having no appetite. So even though they're not hungry, they're still gaining weight. So the body just becomes really sluggish. So our labs for hypothyroidism that we're going to look at. So if they have reduced T3 and T4, so those are the hormones produced by the thyroid. If those are low, then we will see that in hypothyroidism. And then TSH, our thyroid stimulating hormone, that's actually going to be high because again, it's stimulating the thyroid. It's trying to tell it like, hey, wake up, we got to get going. And so because the thyroid is underperforming, that TSH is going to be high. So again, we talked about, improving the gas exchange, so monitor their oxygenation, encourage deep breathing, support cardiac output, so monitor their heart rate and blood pressure closely. And then preventing that myxedema coma that we talked about, so recognizing those signs early on. So hyperthyroidism, this is going to be the opposite problem. So we have too much thyroid hormone, so our metabolism is in overdrive. It's overperforming. And we also see an increase in the sympathetic nervous system activity. So the body, because it's in overdrive, it's like burning through protein, fat, glucose too fast. And this is what that looks like. So they have, it's literally, think of what the hypothyroid symptoms are. It's going to be the opposite of that. So they have an intolerance to heat, the fine straight hair, they'll have bulging eyes, which I'll show you guys a picture of what that looks like. It's common with an autoimmune disorder called Graves' disease. Facial flushing, you'll be able, if you palpate their thyroid, it will feel enlarged. They're going to have tachycardia, so a high heart rate. Their systolic blood pressure is going to be high. We see breast enlargement, again, so we'll see weight loss instead of weight gain. And we will see muscle wasting, some localized edema. We'll see menstrual changes in women so that they won't have periods. Diarrhea is a common experience. Tremors, finger clubbing, so where their nails, they have that clubbing. So that's what hyperthyroidism looks like. So this is a goiter. So this is what that abnormal thyroid enlargement looks like. And then think of it as like the thyroid gland is just overworking. It causes it to swell. So Graves' disease, this is actually the most common cause of hyperthyroidism. So it's an autoimmune disease that then causes hyperthyroidism. One of the hallmark signs is the exophthalmos, which is like the bulging eyes, which is caused by inflammation and fluid building up behind the eyes. It also causes that goiter that we saw. You can see this patient has a goiter as well, due to the overproduction of the thyroid hormones. So usually with these patients, when we're asking them about their history, it's going to show that they have weight loss and an increase. So even though they're really hungry, they're losing weight. They have that heat intolerance. They're having some vision changes. And then we can sometimes see that enlarged thyroid, the goiter. So that's what we'll see on our physical assessment. And then again, that the eyelid retraction that makes it look like their eyes are just kind of like bugging out, for lack of a better term. So the labs that we're going to look at, we are going to see an increase in T3 and T4. So those are going to be high. We're going to see low thyroid stimulating hormone in Graves' disease. The TRAbs antibodies will also be present in Graves' disease. And then some of the diagnostic procedures that we can do, the radioactive iodine uptake. So that is when a patient consumes like radioactive iodine, and they monitor to see how the thyroid responds to that and its increase in hyperthyroidism. And then an EKG can also show some dysrhythmias because the heart is really working too hard. So with our patient who has hyperthyroidism, we want to make sure that we are reducing stimulation. So think of it as like, because their metabolism is in overdrive, they're already kind of amped up. So we want to make sure that their room is comfortable. So like cool, calm, lights dimmed, like relaxing environment. Our drug therapy for hyperthyroidism, we see antithyroid meds. So methimazole is common. The RAI therapy, radioactive iodine, that is an inpatient procedure that they'll do at the hospital. It destroys the thyroid cells and decreases that blood flow through the thyroid gland. So actually what they'll see after that is they'll have symptoms of hypothyroidism because we've destroyed those thyroid cells. And then in really severe cases, they can do surgery, a thyroidectomy, where they remove the thyroid. And post-op with a thyroidectomy, we want to make sure that we are watching for hemorrhage, any airway issues, hypocalcemia, muscle spasms, or any like laryngeal nerve damage, since it's right there next to the laryngeal nerve. So thyroid storm, so this is what the rare but also life-threatening hyperthyroidism looks like if left untreated. So it's again triggered by infection, trauma, surgery, or stress. Or another important thing to note here is that if you have a patient with hyperthyroidism and you're palpating that goiter too much, it can actually cause a thyroid storm. So make sure if you notice that your patient has a goiter, you can palpate it, but don't stay there and push on it for too long. So some symptoms of a thyroid storm: extreme fever, restlessness, confusion, seizures, and even coma. So this requires immediate emergency care. Okay, yeah, we have time. So let's kind of go through this case study. So a 42-year-old female seeing her primary healthcare provider. She reports being tired all of the time, has muscle aches and pains. Assessment reveals a heart rate of 54 beats per minute, which is low, and a blood pressure of 94/60, which is also low. The nurse notes pitting facial edema, especially around the eyes and in the hands and feet. The client's health history includes radioactive iodine for hyperthyroidism. So what condition does the nurse anticipate this client is experiencing?
Hypothyroidism.
Good, hypothyroidism. So again, after the patient has undergone that RAI, the radioactive iodine therapy for hyperthyroidism, it can actually send them into hypothyroidism. So it's going to permanently affect their thyroid function and make it lower. So these patients might end up needing to take Synthroid forever as well. So thinking hypothyroidism, the primary healthcare provider orders lab work that indicates or that includes thyroid function tests. So with hypothyroidism, what results does the nurse anticipate?
Beat.
So with hypothyroidism, we are going to see decreased T3 and T4, and then increased thyroid stimulating hormones.
So it's increased for T3 and T4.
No, for hypothyroidism, it's decreased T3.
Decreased.
Yeah.
Increased,
Increased thyroid stimulating hormone. Yeah.
how backwards.
No, you got it. I know. It's good. Okay. So which teaching points will the nurse include about this condition for the client experiencing hypothyroidism? And this is a select all that apply. Does anyone see any that just stand out to you as like, I know this is correct? You can just shout out the letter.
B,
Dave, one more time, sorry.
D,
Did you say B?
that is C.
Oh, C, sorry. Yeah, C is one of them. Good. Let me turn you guys up a little bit. Okay. So B, C, D, and E. So we want the reason A is not correct is because we want the client to have a high fiber diet because of hypothyroidism. We can see some of that constipation. But yeah, we want to make sure that they are monitoring their sleep. And then any changes in like gait or development of tremors could require an alteration in dose or replacement of thyroid hormone, which again would be done with Synthroid. And then our last question. So the nurse has provided teaching about hypothyroidism. Which client statement indicates that further nursing teaching is needed? D. So yeah, again, that Synthroid, that's going to be a lifelong therapy that they will be on. So, all right, let's take a little break and come back here at 8:55 and we'll do some flashcards to practice our thyroid stuff.
So what was the, where are these? Yeah, we'll get yesterday.
Oh, no.
I know.
Yeah.
You know what? So
Of course, the nasal drip. I went through my house, but always got it.
Why did they?
I don't know, I just woke up yesterday, just.
You know why? Dude, I woke up yesterday and I was right on my right nostril. Did I give you one? Yeah. I want to see if there's a picture.
There's probably not. I bought a bag, but I already ate it all. Big bag. I'll buy some this weekend and bring it, yeah. We always take turns eating the beef jerky out.
Hey, I have a question. Understanding of like that in the meeting too, there's a lot.
I gotta do my thing first, but I started.
I started it and then I finally got to the point where I was like, I have to go on with it. I did my girls, I didn't forget. I also did my journal. I didn't do the journal.
You what?
I did the pictures, but I didn't do the journal.
What do you do in the journal? Oh, for how long? is that?
Basically explain what you did. So it's just
Yeah,
like a freaking pill, that's all I did.
Oh, yeah, you didn't get to take out a.
Because the girl that was-
We're gonna have to teach. We're gonna have to teach Lindy how to speak up, like that TikToker's thing. That's my purse.
Well,
What's
yeah,
my purse? I told Mary what you do.
No, I completely forgot. We were walking up to the hospital. No, we're not. Yeah. We walked out, stepping down, we walked up to the hospital, and she was like, "Oh, is there anything?" I said, "No, she's not." It was only me and you out eating, and then I saw you and I was like,
Yeah,
"Oh, I feel so bad."
yeah.
So if you want, you can, well, it's okay, because there's freaking beer.
Is there? Made your day, didn't it? Don't eat them all.
So it
Waking up that
But
early
she's
and that
so
drive,
thriving.
I was wiped out yesterday. I was so tired.
I can drive to Tonka, and if I can drive somewhere even.
All right, go ahead and kick back into it. Um, and I need everyone unmuted for this next activity that we're going to do. But also while you guys are doing that, I wanted to let you know about an opportunity, and I need to double check the date and time. Hold on, let me open my email here. I want to make sure I'm telling you the right info. So. This is going to be. In Enid, at the Hammer Williams headquarters on Monday, September 22nd. And it's going to be from 8:30 to 10:30. So the opportunity is that they usually have about 20 to 25 patients come through to get a flu shot that day. And Dr. Ritchie and Ms. Easterly will be there to, of course, help you and practice your IM injections. The only caveat is that they only have enough room for 5 students. So to make it fair, I'm just gonna say the first 5 people to email me can be the 5 that go. So just wanted to throw that out there. If you're interested in going and you wanna go, shoot me an email saying that you wanna go to the flu shot clinic. And then the first 5, I will send that info on to Miss Easterly and Dr. Ritchie, and you guys can meet there for that. So it's in Enid. Any questions?
What date was it again, sir?
So it was, or let me pull this up again. So that was going to be Monday.
We're in class.
I just had it. Hold on, sorry. Monday, September 22nd, from 8:30 to 10:30 in the morning at the Hammer Williams headquarters in Enid. Which I'm not sure where that is, but I'm sure Google could tell you.
Don't we have class on that day?
Yeah, we have class.
Holistic.
Yeah.
Oh, you have pharmacology?
Yeah, we have foreign.
Yeah.
Well, we could coordinate, I'm sure with Dr. Elliott, if you wanted to miss for that morning anyways and go do that. So email me if you're interested, and if you are, we can talk to Dr. Elliott and coordinate that so that you can go. Okay. All right. So let's go ahead and kick off here. So we're going to go through some flashcards that are going to have a symptom on it. And what I would like for you guys to tell me is if you think it's associated with hypothyroidism or hyperthyroidism. Let me turn you up again here. Sorry. So depression or mental sluggishness. Hypothyroidism, so caused by that slow neurologic function. Thyroid storm. The life-threatening complication caused by severe hyperthyroidism.
So is that why you consider hypo, like the people's, because hyper can throw you into thyroid storm?
Well, hypo can also cause a mix of things, but that's pretty rare, so.
Okay.
Okay, exothalamus, the bulging eyes. Hyperthyroidism caused by Graves' disease. Cold intolerance. Hypothyroidism. Weight gain despite normal or reduced caloric intake. Hypothyroidism caused by that slowed metabolism. So dry, coarse skin and hair. Hypothyroidism. A goiter. Hyperthyroidism. Treatment, radioactive iodine therapy. What do we see that for? Hyperthyroidism. Good job. Destroys that active thyroid tissue. Dang, you guys are on it with the emails. Okay. Bradycardia. Hypothyroidism related to that decreased cardiac output. Treatment option, the nasal, we didn't talk about PPD, but it's another treatment option for this. I think I heard someone say it. Treatment for hyperthyroidism and inhibits that thyroid hormone synthesis. So monitoring for myxedema coma,
Is that hypo?
hypothyroidism.
Did you just give us an answer?
Yeah, I did technically just tell you that, so. Weight loss despite an increased appetite,
Hypo.
hyperthyroidism, good. Insomnia,
Hypo.
hyperthyroidism related to the overactive metabolism. Frequent loose stools, diarrhea,
Hyper.
hyperthyroidism, good. Related to that increased GI motility. Increased reflexes,
Hyper.
hyperthyroidism, good.
So with hyperthyroidism is just kind of like everything's just sped up.
It's on overdrive, yeah. Here's an ad for us to enjoy. Sorry, I didn't pay for the paid version. We're all gonna see the Downton Abbey movie.
Downtown.
I love that.
That's right.
I am.
Okay, treatment option, thyroidectomy, surgical removal.
Hyper.
Good. Fatigue and lethargy,
Oh.
hypothyroidism, decreased metabolism, tachycardia or palpitations.
Hyperthyroidism.
Hyperthyroidism, good. Heat intolerance,
Hyper.
hyperthyroidism. Treatment option, levothyroxine, also known as Synthroid,
Hypo.
hypothyroidism, replaces that thyroid hormone. They will be on it for life. Warm, moist skin with fine hair,
Is that hyper?
hyperthyroidism. Irritability, anxiety, or restlessness,
Hyper.
hyperthyroidism. Did I do all of these? I think I forgot to hit shuffle. So it's like doing all the hypothyroidism first and all the hyperthyroidism second. Oh, no, wait, here, okay, constipation,
Hypo.
hypothyroidism. Good job. Right, and then that should be available to you. Available. Or say that. It looks like it's available now, so. No, it says until noon. Okay.
That's under this week's content.
Oh, but it keeps going up. Yeah, it's under this week's content. I'll make sure to make it available to you before. Okay, you should be able to see it now. All right. So let's shift gears here. We are going to launch into diabetes.
Diabetes.
Pull it up here. Okay. Any questions on the thyroid stuff before we move on?
No.
Feeling good? Okay, if I'm echoing, you guys can mute it again now, but. Alrighty, let's move into diabetes here. So, diabetes, something that you will see a lot with patients, so it's good to, if you're gonna lock in on anything, let it be on this, because we're gonna dive into it and it will definitely be something that you see often. So diabetes is a chronic condition. It's related to impaired glucose metabolism. So the key feature that we see with both types of diabetes, type 1 and type 2, is hyperglycemia. So too much glucose in the blood. Now, what causes that breaks down with the two main types of diabetes. So the two main types are type 1 and type 2. So what causes that hyperglycemia or too much glucose in the blood with type 1 diabetes is that the body isn't producing any insulin. So type 1 diabetes is an autoimmune disease that causes destruction of the beta cells in the pancreas, and we'll talk about that a little bit more here in a minute. But because the body isn't producing any insulin, it's causing that hyperglycemia. So that's why usually type 1, because it's an autoimmune disease, is diagnosed a little bit earlier in life. Whereas type 2, we see it being diagnosed later in life, and it has some risk factors, like genetic risk factors and obesity, and the things that cause that hyperglycemia in type 2 diabetes is insulin resistance, or the body just isn't producing enough insulin. So we talked about insulin. It's a hormone. It's part of that endocrine system that we just talked about. It's a hormone secreted by the pancreas. Good. So that insulin is kind of like a key that unlocks the door of a cell for glucose. And then whenever that glucose is going into the cell, it helps to regulate our blood sugar. So in type 1 diabetes, there just isn't a key. Like the body isn't making the keys to open the door to the cell. And then in type 2 diabetes, it's either that the key doesn't fit in the door or it just doesn't lock well. So, or there just aren't enough keys. So that's a good analogy to think of it as. But without insulin, the glucose stays in the blood and it causes organ damage over time. So our normal blood glucose, depending on if the person is fasting or if they've just eaten, but our normal blood glucose is somewhere between 60 and 150. And it's regulated by a balance of glucose uptake by the cells and glucose released by the liver. So glucagon, that's our backup hormone that prevents hypoglycemia. So if the body senses that our blood sugar is getting too low, it releases that glucagon to help bring the blood sugar up. So without insulin, those cells will starve, even though there's plenty of glucose in the blood, and that leads to some fluid and electrolyte imbalances. Let's talk about our pancreas. It is a very complex organ that is very important to our body. So when we're intaking food, the pancreas recognizes that and recognizes that we need to start releasing insulin. So our pancreas is kind of like our glucose control center. The islets of Langerhans, those are tiny clusters of cells that regulate glucose within our pancreas. So on those islets of Langerhans, there are alpha cells, which release the glucagon. So again, that raises our blood sugar. And then there's beta cells, which releases insulin to help lower our blood sugar. So those two things are working together. It's that negative feedback mechanism that we talked about in the endocrine chapter. Those work together to control our blood sugar in our body. So the reason insulin is important is it allows our cells to store and use carbs and fats and proteins. So without it, the body just burns fat uncontrollably, which releases ketones. And we don't want too many ketones because that can cause some organ damage. So with type 1 diabetes, as we're kind of looking at these different cells in the pancreas and how they help to control our blood sugar. So with type 1 diabetes, that's an autoimmune disorder where those beta cells in the pancreas are destroyed. So our body is just not producing insulin. It's usually diagnosed in adolescence and youth, and it requires lifelong insulin. So because the body isn't making its own insulin, that person is going to have to take insulin for their entire life to supplement for that. Type 2 diabetes, that is more related to insulin resistance, and then also just the body not being able to use that insulin well when it is created. It's strongly linked to obesity, a sedentary lifestyle, poor diet, and high blood pressure. So here's a good chart that I would pay close attention to when I'm studying for my exam. That kind of breaks down the difference between type 1 diabetes and type 2 diabetes. So again, type 1 is that autoimmune disease that destroys beta cells in a genetically susceptible person. A viral infection can trigger it, which is why if someone has undiagnosed type 1 diabetes, usually if they come to you in the ER with all of the signs and symptoms of a diabetic crisis, which we'll talk about here in a minute, but they will say, oh, I just got over the flu. I just got over the flu, some kind of viral infection. So it can trigger that autoimmune response, which can trigger the type 1 diabetes. There's non-modifiable risk factors. So this isn't something, unfortunately, that can be prevented. Diagnosed a little bit early on in life. And again, this person will be dependent on insulin. So with type 2 diabetes, there are some modifiable risk factors, usually with these patients increasing their level of activity and making some modifications to their diet can really help to control that insulin resistance and the symptoms of their type 2 diabetes. So it's usually diagnosed in adulthood. Insulin may not always be required. Sometimes it can just be managed with diet and exercise and other medications like metformin or GLP-1 medications that help with that insulin resistance. And then a lot of times with these type 2 diabetes patients, we see a lot of cardiovascular issues, and these things also put them more at risk for diabetes. So hyperlipidemia, meaning that their lipids are high, their triglycerides. Hypertension, so their blood pressure is high. There are increased risk for clot formation, like blood clots, and they usually 60 to 80% are obese. So metabolic syndrome, this is something that it's a combination of risk factors that puts a person at much higher risk for developing type 2 diabetes. So metabolic syndrome is the combination of abdominal obesity, hyperglycemia, so like chronic high blood sugar, hypertension, that high blood pressure, again, hyperlipidemia, the higher triglycerides and lipids. So think of it as kind of like like those four things combined push the body towards insulin resistance, which makes our patient more susceptible to developing type 2 diabetes. Genetics are also a risk factor for type 2 diabetes as well. So if you have a patient that comes to you with type 1 diabetes that is not controlled, this is what it will look like. So think of the 3 P's, so polyuria, polydipsia, polyphagia. So what that translates to is increased urination, increased thirst, increased hunger. So some of the things that we will see with that is weight loss, fatigue. They're more prone to infections, so we'll see an increased frequency of infections. It has a rapid onset typically, so they will come to you like already in a diabetic crisis. They're dependent on insulin. Again, there's a strong genetic link there. And then the peak incidence, so when most people are diagnosed with this, is usually from ages 10 to 15 years.
Is type 1 the one where they have like their breath smells like fruit?
That can be with either type of diabetes, so that's caused by like an increase. Bethany was asking the fruity breath smell. So that can actually be with either type of diabetes. That's related to an increase in ketones in the body. So for type 2 diabetes, this is what we usually see here. So sedentary lifestyle, family tendency, there is still a genetic link there with type 2 diabetes. The average age to be diagnosed is 50 years. They usually have an increased, or they have hypertension, decreased fatigue and energy levels, typically obese, but not always. They deal with recurrent infections and like wounds that don't heal very well. And then again, we see that polyuria, the increased urination, polydipsia, the increased thirst. And then the finger stick blood sugar is usually greater than 126 if untreated. So looking at some of our chronic complications that we'll see with diabetes, again, this is something very important to commit memory if I were studying for my exam. There are two different branches of our chronic complications that we'll see. So there's macrovascular complications, which involves like big blood vessels, and then microvascular complications, which involves the tiny vessels. So the reason we're seeing these types of issues with diabetes is because that chronic hyperglycemia, it damages vessels because the sugar, simplified way to think about it is like the sugar crystallizes inside the pipes, basically making them stiff and clogged. So some of our macrovascular complications that we'll see, the big blood vessels, we see cardiovascular disease with the heart. We see a stroke risk increasing, the brain, so those are our big blood vessels. Some of the microvascular tiny vessel complications that we'll see are with the eyes, we'll see retinopathy leading to blindness. With kidneys, we'll see nephropathy. With the nerves, we'll see neuropathy, so decreased sensation, and we'll kind of break each of these down here. So again, the type 2 diabetes is strongly linked to hypertension, high lipids, a sedentary lifestyle. So all of these things lead to modifiable risk factors that the patient can try to control, like their diet, smoking, and exercise. So all of those things contribute to those cardiovascular, the macrovascular changes. Cerebrovascular, that's another macrovascular change that we see. So for patients with type 2 diabetes, their risk of a stroke is 2 to 4 times higher. That that's related to the severe carotid artery atherosclerosis because they have those higher lipids. So there's that buildup of plaque in the arteries, which puts them at an increased risk for stroke. So some of our microvascular changes that we see, so the tiny vessel changes, nephropathy, that is reduced kidney function. So diabetes type 2 is actually the #1 cause of end-stage renal disease. The risk is increased with poor glucose control and uncontrolled blood pressure. So it's putting a lot of, it's making those kidneys work extra hard. So some of the early signs of nephropathy, that reduced kidney function, that kidney damage, is if you are doing a urinalysis on your patient and you notice protein in their urine, which is called microalbuminuria. So that is whenever we see that protein in the urine, that's a sign that those kidneys are starting to experience some damage. And if it's left untreated, the patient could possibly need to be on dialysis for the rest of their lives. So neuropathy, this is related to the nerves being damaged. So you'll notice with a lot of patients with diabetes, they lose sensation, especially in their peripheral extremities, so like their hands and their feet. So it's a slow nerve damage. It usually starts with pain, so they'll have that like stabbing nerve pain, but then eventually leads to a loss of sensation. So that can unfortunately lead to foot ulcers, infections, deformities. The reason that's an issue is because they can injure, for example, their foot and have no idea that they've injured it because of that loss of nerve sensation. And then that wound is left untreated and it can lead to an infection. And because people with diabetes have slow wound healing, it takes a long time for that infection to clear up, and it can lead to other complications like sepsis, and so it can get pretty serious. So retinopathy, this is one of our microvascular changes, again, that we see with diabetes. Retinopathy is actually the leading cause of blindness in diabetics. So that microvascular change, it leads to like poor retinal circulation and edema, which causes that vision loss, and it just gets progressively worse over time. So when we are assessing a patient with diabetes, we want to ask them if they've had any changes in their weight. So obesity again is a risk factor for diabetes type 2, but patients with diabetes type 1 will often lose a lot of weight before being diagnosed. So it's important to ask if they've had any changes in their weight. Again, we want to ask them about polyuria, polydipsia. Have they had any excessive urination, excessive thirst? And then we want to ask them about their overall immunity. So have they had any recent or recurring infections, any wounds that are really slow to heal? And we want to ask them about their modifiable risk factors like their weight, their level of activity, and then any non-modifiable risk factors that they have, like a family history of diabetes or their age. So when we are looking at our blood glucose values, a normal fasting blood glucose, so that is once the patient has been fasting, typically for at least 4 hours, but it depends on the lab. But if they have been fasting and you check their blood sugar and it's less than 100, that is what we consider normal. So if it's above 126 as a fasting glucose on 2 occasions or more, that is typically one of our indicators that the patient might be diabetic. A glucose tolerance test. So what that looks like is we give the patient a really sweet drink that they will consume, and then they will typically wait for about an hour or 2 and then have their blood drawn. So normal after that is that we want it to be less than 140. But if it's greater than 200, that can also potentially point to a diabetes diagnosis. But really our gold standard for looking at someone's glucose control over a long period of time is their hemoglobin A1C test. So ideally we would like that to be between 4% and 6%. And what that A1C is testing, so when glucose levels in our blood are high, that glucose will bind to hemoglobin in our blood. So what the A1C test is measuring is how much glucose bound to that hemoglobin over a 2 to 3 month period. So it really shows us a bigger picture of how a person is managing their blood sugar levels versus just a quick snapshot whenever you're poking their finger and checking their blood sugar that way. So that hemoglobin A1C is kind of our gold standard to see how, like, what have your blood glucose levels looked like over the last 3 months. And here's a helpful chart for you to look at there. So our drug therapy for treating diabetes, there is a table in your textbook, 56.5, that you can look at, but so it's drug therapy is, again, it's indicated for all patients with type 1 diabetes, so type 1 diabetics are always going to have to be on insulin. And then for patients with type 2 diabetes, when their modifiable risk factors are not controlled, we start them on medications. So what some of those medications look like, we have metformin and glipizide. So glipizide, it lowers those glucose levels by triggering the release of insulin from the beta cells in the pancreas. When we have a patient that is taking glipizide, we want to prevent and monitor them for hypoglycemia while they're taking it. They can take it with or just before meals. Glipizide is usually not our first choice because there's a lot of drug interactions, so you don't want to take glipizide if you're on beta blockers or taking an antifungal like fluconazole. It interacts with alcohol and warfarin, so because it interacts with those medications and the way it interacts is it puts the patient at an increased risk of hypoglycemia. So because there are so many medications that it interacts with, it's usually not our first choice for an oral medication for the patient to take. So metformin is another option. It decreases liver glucose production by decreasing the intestinal absorption of glucose, and it increases insulin sensitivity. So it's important to note if you have a patient that's taking metformin, if they are needing to do a CT scan with contrast. So contrast is something that is injected through their IV that helps a radiologist to get a better view of anything that might be going on in the CT scan. But if a patient is taking metformin, they need to stop at least 48 hours before and after they are receiving that contrast material because it can lead to kidney damage. GI symptoms are common with patients taking metformin. They'll usually report diarrhea. So for insulin, you guys are hopefully familiar with insulin by now. It's a subcutaneous injection. So some of the things that can affect the absorption of insulin, things like heat and exercise will actually increase the absorption of insulin, which isn't always a good thing because that can drop their blood sugar too much. And then some of the things that can decrease the absorption of insulin is if they are injecting themselves in a spot that is frequently used and they've built up some scar tissue there. So that's why we want to make sure to educate our patients on rotating their sites for insulin injections. There are different types of insulins. We have short acting, which work really quickly, like within sometimes as quickly as 30 minutes up to like 1 or 2 hours. Intermediate insulin, which kind of works, the peak is like 2 to 4 hours, and then long acting insulin, which that's something that the patient takes usually on like a maintenance dose daily and just gives them like long-term glucose control through the day. It usually peaks at like somewhere between 12 and 20 hours. So, considering this, the patient's prescription for insulin can look different. So they can be doing it once daily if it's like a long-acting insulin. They can be doing it twice daily if it's an intermediate acting insulin. But usually the short-acting insulin is what they will take before a meal because it works a little bit more quickly and can help with that glycemic control. So some things that we want to educate our patients on if they are taking insulin and keeping it at home, they want to store it somewhere cool. So we want the temperature to be between 36 and 86 degrees Fahrenheit. So we usually tell them to keep it in the fridge. Once it has been opened and the vial has been pierced, it's only good for 28 days. So they need to write the date on the vial when they open it. We want to tell them to protect it from sunlight. Again, refrigerated if they're not using it. Have a spare supply ready just in case something happens with the supply that they have. Again, this is a life-saving medication, so it's not something that we want them to run out of or have any issues with. If they're traveling, they need to always make sure that they have some with them stored in a cool, dark area, like a cooler. We want them to inspect the vial, check the expiration date, and then make sure they're using the correct syringe size. So again, this is a subcutaneous injection. So we want to make sure that they're giving it to themselves subcutaneously. These are some of our common insulin injection sites. As you all are familiar with, we have the area in the fatty subcutaneous part of the stomach, the back of the arm. Those are our two most common sites. If the patient has a lot of scar tissue there, you can also do it on the interior aspect of the thigh or on the back of the buttocks, just in that subcutaneous tissue. But for the most part, you'll just see us rotating between the back of the two arms and then that area around the abdomen. So when we have a patient who is hospitalized and they're diabetic, something that we want to remember is that these patients are under stress because they're hospitalized. And so stress increases that risk for hyperglycemia. So that can cause longer healing times or increased risk for infections. We want to make sure that we are monitoring them for signs of hypoglycemia when they have an order to do NPO, nothing by mouth, like for a procedure. we want to make sure that we know our facility's treatment protocol for hypoglycemia. It will look different from facility to facility, but typically what that will look like is if your patient has a low blood sugar, so if they're displaying some of those symptoms of hypoglycemia, like shakiness, headache, lethargy, check their blood sugar. And your treatment is going to depend on if your patient is awake or not. So if their blood sugar gets too low, they could lose consciousness. And if that's the case, that's when we're going to give them IV dextrose. So it goes through their IV, it raises their blood sugar. But if they're alert and talking to you and able to swallow, there's usually a protocol for carbohydrate replacement. That could involve like peanut butter crackers, juice. Sometimes the hospital already has like pre-packaged glucose gel that you can give them. It's just important, you want to make sure that you are partnering it with something that has protein in it, because if you just give them some apple juice, it's going to like spike their blood sugar and then it's going to drop again really quickly. So we want to make sure that we are partnering it with something that has protein in it, like peanut butter. If they are taking basal insulin, so basal just means like a maintenance dose, so that's kind of that long acting insulin that they're taking every day. It can be given if the patient is NPO, but at a reduced dose. So that is per the provider's discretion and order. So make sure you're checking with the provider before you give that. The short acting insulins, we do not want to give to the patient when they're NPO because it will cause hypoglycemia if they're not eating food. So exercise is a great way for our patients with diabetes to manage their symptoms. So it's recommended that they exercise a total over the span of a week for 150 minutes. That should be broken up. They typically won't tolerate 150 minutes all at one time, but like 30 minutes 5 times a week is a good pace to go. We want, especially for our elderly patients, to educate them to start slow and in short sessions, don't overwhelm themselves. But the benefits of exercise is that it increases that insulin sensitivity and helps to lower their glucose. Safety considerations, of course, we want them to wear good footwear because if they injure their feet, they may not know that that has happened. And then an unfortunate common thing that some people with diabetes experience after exercise is hypoglycemia. So because it's increasing that insulin sensitivity and lowering their glucose, if they aren't like eating a snack while they're exercising, it could actually drop their blood sugar. So we want to educate our patients to look for that. If a patient has ketones in their urine, that can indicate that their insulin levels are not adequate, and that exercise should be withheld for that day. So nutrition, that's another important consideration for our patients with diabetes. We want to make sure that we are working with a patient and their family and a dietitian to provide a holistic nutrition plan that they can actually stick to. If it's not adaptable to their culture or their financial status or their lifestyle, it's not going to be sustainable for the patient and they probably won't be able to stick to it. So the key thing for nutrition with our diabetic patients is carbohydrate counting. So we want to make sure that they are keeping track of how many carbs they're having for each meal, because that determines how much short-acting insulin they may need. And it's important for it to be realistic and flexible. They still need to eat carbs. Like, we need carbs for our bodies to function. So telling them to like go on a keto diet and totally cut out carbs would actually be pretty detrimental for them. So we want it to be a low-fat diet. If they are eating fats, focus on healthy fats, like fish and eggs. And then we also want to educate them on alcohol-induced delayed hypoglycemia. So our diabetic patients, if they drink alcohol, they are at risk for experiencing hypoglycemia after they've started drinking. So we want to educate them on that, make sure they're eating snacks and monitoring for symptoms of hypoglycemia, and pace yourself. So again, foot injuries, those are the most common cause of hospitalization in diabetics. So we want to educate our patients on inspecting their feet daily wearing clean socks and well-fitting shoes. They need to make sure that they're never going barefoot, walking around, because if they step on something, they may not feel it. We want them to avoid any hot or cold, extreme water temperatures because they could injure themselves not realizing how hot or cold something is. If they do notice an ulcer on their feet, they need to go see a provider. Don't do any self-treatment options because they are at that increased risk for infection. So we want to address it quickly. So when we're looking at the types of shoes that we want them to wear, we are looking for like well-fitting laced tennis shoes. So unfortunately, like things like Crocs, even country Crocs, are not a good option. Shoes should be protective and fitted. So some symptoms of hypoglycemia that we want to monitor for. When you're thinking of hypoglycemia, think like neurological function. So our brain needs that glucose to perform its most basic functions and also its more higher executive functions like decision making. So when a patient is experiencing or anyone is experiencing hypoglycemia, they're going to have that decreased neurologic function. So if there isn't enough glucose, those neurotransmitters aren't produced and communication between the neurons breaks down. So that's why as hypoglycemia worsens, neurological symptoms worsen as well. And you can see from this graphic I've made that it just gets progressively worse. It starts with the weakness and fatigue and difficulty thinking, and then moves into confusion and behavior changes. And then as it gets progressively even more serious, we see like seizures, loss of consciousness, brain damage, and even death. So that's why it's important that we are able to monitor our diabetic patients for symptoms of hypoglycemia and checking their blood sugar if we feel that they might be experiencing hypoglycemia. So some common causes of hypoglycemia in diabetic patients, if they have too much insulin versus the food that they ate. So most diabetics will usually give themselves their short-acting insulin before they eat. But then if for some reason they don't eat as many carbs as they thought, then that can mean that they took too much insulin and it can cause hypoglycemia. And then skipping meals can also cause hypoglycemia. Alcohol, again, it decreases that liver glucose production and can cause our patients to experience hypoglycemia. Kidney disease decreases that insulin clearance, so the insulin lasts longer in the body and can cause hypoglycemia. So all of these are things that we need to educate our patient on as common causes so that they can be aware. So if you have a patient that is in the hospital experiencing hypoglycemia, we talked about some of this, but again, know your facility's protocol. But a good rule of thumb is the rule of 15. So if it's mild hypoglycemia, so between like 40 and 70, give 15 grams of carbs and recheck in 15 minutes. Moderate hypoglycemia, so between like 30 and 40, we're going to give 30 grams of carbs, stay with your patient, check again in 15 minutes. And then severe hypoglycemia, we're going to skip the carbs. If it's like less than 30, your patient's probably not conscious anyways. So we're going to anticipate giving that IV dextrose, which you can see pictured here, or glucagon IM if they don't have IV access available. But the important thing to remember when you're treating with any of these options is that the effects are temporary. So the blood sugar will rise, the patient will hopefully start to have a resolution of their symptoms, but it's very possible for their blood sugar to then start tanking again. So we want to keep a really close eye on them and monitor them, and then administer these therapies again as needed. So if our patient is at home, of course, at that point, they typically don't have like IV access. So they can keep glucose tablets like the ones that are pictured here, or we can just educate them on needing to always have some snacks close by and available in case they start displaying any symptoms of hypoglycemia. Some good examples of 15 grams of carbs. So that's like half a cup of fruit, 8 ounces of skim milk or like 6 saltine crackers. Milk is a good option because it contains both that like sugar and protein component. So they don't need to just have milk, you know, if they want to have something that has a little bit more sugar to feel better quickly, they can, but if they pair it with milk, that will help them. So some things, so 30 grams of carbs would just be twice of those options. But then for our patients at home, if they're experiencing severe hypoglycemia, so like if a family member finds them unconscious, they need to be educated on how to give the patient glucagon intramuscularly. And then repeat the dose in 10 minutes if the patient is still unconscious. And of course, anytime you find someone unconscious in a home setting, we're going to be calling 911 and transporting them to the emergency department ASAP. Oh, sorry, and CHO stands for carbohydrate. So, what does that patient education look like? Again, we want to teach them the symptoms of hypoglycemia. So hypoglycemia equals neurological symptoms. We want to teach them about the steps that they need to take to treat themselves that we just went over. It helps if they wear a medical alert bracelet. That way, if they're ever out in public and not with a friend or family member who's aware of their condition and they're found unconscious, someone can know that they are a diabetic. They need to keep a carb source nearby at all times in case they start to experience hypoglycemia and aren't feeling well. They can have that carb source. And then again, the family should be educated on how to give the glucagon injection and where it is located in case it needs to be found in an emergency. So of course, our number one priority for patients with diabetes is to keep their blood glucose controlled. So as we talked about, when that blood glucose is out of control, it causes these macrovascular and microvascular complications. And I want to really emphasize again that it's important for you to pay attention and memorize to what those macrovascular complications are, what those microvascular complications are. But when that blood glucose is uncontrolled, it leads to those complications. So we want to control their glucose. We want them to do regular vision screenings to make sure that they're not experiencing any retinopathy. We want them to regularly follow up with their doctor to check their A1C and ensure that their kidney function is optimal. We want to, again, educate them on taking care of their feet, inspecting them daily, wearing the well-fitting shoes. And so all of these things to help our patient from experiencing those complications of diabetes. Okay, let's do a little knowledge check here. So when caring for a client having a hypoglycemic episode, which symptom requires immediate nursing intervention? So the answer is B, which was confusion. So glucose is necessary for brain function, so confusion could be a sign that the brain isn't getting enough glucose and the patient could be moving in a direction of hypoglycemia, and we want to treat that. Okay. Well, let's take a little break, and then we will come back and work on a couple of things together, and then we'll move into our escape room. Let's take a slightly longer break, go stretch your legs, eat a snack, prevent hypoglycemia. Come back at 10 o'clock, okay? Okay, let's go ahead and come back together. Hope everyone got a snack. Don't want any hypoglycemia happening. Let me pull up screen so you guys can see this. Hopefully. Okay, so dang it. I'm going to attempt to try something. The computer will let me. Okay, well, while I'm getting this pulled up, there is I was just gonna let you guys know, if you emailed me about flu shots, I will talk to Dr. Elliott and make sure that that is approved by her, and I will let you know one way or another what she says. So, and we're hoping in the future we can kind of get some more options so that more than just 5 people can go, but we thought that would be a good opportunity for you to practice your IM injections if you could. Bear with me for a second, guys. Well, while I'm getting this pulled up, if you guys want to open, if you don't already have a laptop open, go ahead and go to API. We are going to try something that I have not done yet, so hopefully it works. But when you get to ATI, see if it'll let me share my screen now. Okay. So you will scroll down to The video case studies are in 3.0, which is at the very bottom on mine. And then we are going to go to type 1 diabetes. Sure.
Which one of those here was?
Video case studies are in 3.0. There's a ton of them, so just scroll down. Here we go. It says metabolism, type 1 diabetes, mellitus. And then hit begin case. You can tell I already did this summer. My response was just smiley face. Okay.
It's
So,
not open for us, it's grayed out.
oh no, okay. Okay, well, TBH, the time that it would take to go into ATI and get that pulled up is just too much time, and I want to be respectful of your time, so we'll try that again next time I'm lecturing. Not that specific one, but we'll try doing an ATI thing. Okay, sorry about that, guys. So pivot, you still need your computers, but go to Blackboard. And you should see under the week's content an endocrine escape room. If you will pull that up. And then it's up to you if you want to work individually or buddy up with someone, you're more than welcome to. We are going to work on this for about 15 minutes. And then we will come together and review our answers. So does everyone see that? Hopefully. So go ahead and get started, and at 10:20, we will see if everyone was able to escape the escape room. Is anyone still working? Okay, let's go over our answers here. So, this small but mighty gland is the base of the brain and is often called the master gland because it controls other glands. It's about the size of a pea.
Pituitary.
Pituitary. Okay. Which hormone secreted by the thyroid gland helps regulate the body's metabolism and energy use? It starts with a T and has a number.
T4.
T4. A patient comes in with these symptoms: unexplained weight loss, heart or heat intolerance, rapid heartbeat, and bulging eyes. Which endocrine gland is overactive? The thyroid. Which small glands located on the back of the thyroid help regulate calcium levels in the blood?
Parathyroid.
Parathyroid. This gland sits on top of the kidneys and produces cortisol and adrenaline to help you respond to stress. What is it called?
Adrenal gland.
Adrenal gland, good. Your patient has high blood sugar because they're not producing enough insulin. Which gland is affected?
Chris.
Pancreas. This tiny gland in the brain produces melatonin, which helps regulate your sleep-wake cycle. What is it called? Sure that we went over that one. You mentioned that. This is your pineal gland. And then which hormone, also called epinephrine, is released during the fight or flight response to an increased heart rate and alertness? Adrenaline. All right, let's see if we did it. You did it. You saved the body. Good job. Okay. So our last thing for today is to do a Kahoot. Have you guys done a Kahoot yet? You've done one? Okay. So I am going to pull this up and have you guys log on. Oh, let me log in really quick. Maybe just a second. Okay, go ahead and get logged in.
Was it like gonna, are you gonna give it something? Is that in?
Yeah, that's the pin. 5137. You can just scan the QR code with your name.
I'm not sleeping.
Just like back for everything. Thumbs up if everyone is logged in. That needs one. Or I guess raise your hand if you're still getting logged in.
No, I don't. How should I try? Three.
Back and rolling. May the odds be ever in your favor. Good, so that is petechia. So select all that apply.
I clicked the first one. Yeah, thought it was wrong.
Okay, sorry fam, apparently some people would at least like.
That's me as long as you didn't put purple.
Yeah, I think as long as you didn't select nothing, you're good to go. So the rest are all symptoms of hypoglycemia. True or false? That is true. So normal blood glucose is between 60 and 150. Stage 1, good job. It is non-blanchable redness or erythema, as it's called, and there's no like skin, no break in the skin yet. So that's stage 1. That is a stage 2. Good job. Yeah, that's a stage 4. So we saw it had passed through the subcutaneous tissue. We could see some muscle. So that is a stage 4 pressure ulcer. Job. Process of elimination. That's a stage 3. True or false? Good job. So hyperthyroidism, that metabolism's in overdrive. We want to create a calming, soothing, quiet environment for them. Good. So for our symptoms, for someone who is undiagnosed with type 1 diabetes, we're gonna see that polydipsia, polyuria, and some weight loss. Weight gain is more associated with type 2 diabetes. Job. You guys are so smart. And so a client with decreased aldosterone would experience increased urine output. True or false? Good job. Yeah, client with hyperthyroidism is going to have decreased T3 and T4 lab levels. Good job. Good. You want to have a high protein diet to prevent pressure ulcers. Good job. Yeah, so Synthroid, what they take for hypothyroidism, that is a lifelong medication. Good job. Okay, now it should let you select all and apply. I don't know why I didn't have that set up on the other one, sorry. Good job. Glad no one put Crunchwrap Supremes. I guess technically an apple a day, but that's not like an official guidance, but I guess that is contributing to maintaining a healthy diet, but I see where you were going with that. True or false? Good, so normal hemoglobin A1C is gonna be between like 4. Once it gets above 5.7%, that's when we start to worry that we might be looking at some poor glycemic control. Good job. Yes, that was false. So our hemoglobin A1C assesses long-term glycemic control over a period of about 3 months. Good, so we want to turn them every 2 hours, assess for malnutrition, keep the skin clean and dry. We don't want to rub those bony prominences when we're turning them because friction can actually cause a pressure ulcer or make a pressure ulcer worse. Good job. Micro, small vessel complication. Blindness, good job. So microvascular complication, retinopathy can lead to blindness. Hypertension and cerebrovascular disease are macrovascular, the large vessel complications. And insulin resistance isn't a vascular issue. It is something with diabetes, but it's not vascular. Good, so the D in the ABCDE assessment, that is diameter greater than 7 millimeters. So if we see a lesion that's greater than 7 milliliters wide, we are concerned about skin cancer. Good. Wash the affected area with mild soap and water. That helps us with pruritus or itchy skin caused by a new substance. Good. So they have tenting where we do that trigger and the skin is not very elastic. That's dehydrated. Good, so if that discharge is thin, watery, kind of light pink in color, that's serosanguinous. That's a normal part of the healing process. We're not concerned about that. If it looks purulent or like yellow or milky, that's a sign of infection, and that's not normal in the wound healing process. Good. We do not want to use salt water if the patient is prone to dry skin. So that left shift bandemia where we see the neutrophils increasing, those neutrophils are a type of white blood cell. That gives us concern for infection. Good job. So yeah, we want to make sure they have a patent airway. If we apply oxygen and their airway isn't patent, then that oxygen isn't really going to do anything for them if their throat has closed. So we want to make sure they have a patent airway. Okay, good job. So our BPD skin test, that is a type 4 delayed hypersensitivity reaction. Good. So yeah, so our priority treatment is going to be that epinephrine, because that is what is going to resolve their symptoms. And if they're in the hospital, we can give that intravenously, so it will work even more quickly. Good. So we should always draw the blood cultures before we start antibiotics, because that can give us a false positive on the blood cultures if we start antibiotics beforehand. Yay! Go team! Woo-hoo. All right. Let's begin. So, any questions about anything?
Our test is next week.
Yes, your exam number 2 is this, like, so a week from today at 8 a.m. Please use this Kahoot to study. It will help you prepare for the exam, kind of give you an ideas of like what topics to narrow in on. And if as you're studying, if you find that there's something you're having trouble understanding or you need help like breaking it down, feel free to shoot me an email. I'm happy to explain it over email, or if you want to meet via Zoom, if you do better with, the face-to-face conversations, I'm more than happy to meet via Zoom. So don't hesitate to reach out to me and I'm more than happy to help. Any other questions?
What was the code for this code?
Oh, it won't be whenever you access it on Blackboard, you don't need the code. You can just click the link and it'll just pull it up and you can do like flashcards or
Okay.
whatever you want to do for your preferred.
Where do we find it in Blackboard?
Let's make it available. Okay, you should be able to see it now. Any other questions?
Are we gonna get an exam review for this one?
That was your exam review.
Oh.
What do you mean?
Like a study guide?
Oh, well, there's a Kahoot and there's your activity statement.
Wow.
Yeah, study guide, so.
You have it, well. Will our next exam be next Thursday?
Yes, so next Thursday at 8 a.m., that'll be your second exam, and it is going to be over the hair, skin, and nails, inflammatory, immunity, allergy, autoimmune infection, and then all the endocrine stuff that we went over today. So the content we covered last week and then the content we covered this week, that's what will be on your exam.
I did that one.
I'm gonna take it now.
Any other questions?
Our schedule says one.
What was that?
Yeah.
Sorry, I may have to say it again. I couldn't hear you. Was there another question? We feeling good?
Do we have lab today?
Yes, we do have lab at 1 o'clock. You will do a simulation, so please return to your labs at 1 o'clock and we'll do an endocrine sim. All right. Well, you guys have a good rest of your day until 1 o'clock when you're back. See you later.
Yes, we do. Do you want me to think about it?